Hey everyone, welcome back to the channel. I'm Dr. Michael Lenz. I'm an internist, lifestyle medicine physician, pediatrician, and clinical lipidologist, as well as author and podcast host of Conquering Your Fibromyalgia. Today, we're diving into a really important discussion about hormone therapy, women's health, and the impact of medical research on real lives. You won't want to miss the insights from Dr. Pinkerton and the powerful stories shared in this presentation. So stick around.
Excellent. Thank you so much. Our next presenter is Dr. Joanne Pinkerton, also presenting for Dr. Joanne Manson.
So I'm going to start by being the voice of Dr. Manson, who wanted to be here. She is at the Endocrine Society out in San Francisco, but she really wanted to present her data to show how to combat this misinformation. Because just like Barbara, when the WHI came out in 2002, the phones rang off the hook. I had an open session. 600 women showed up, just frightened to death that they had taken something that was going to kill them or give them dementia. And so they suffered, and 25% went back on. But this data that I'm going to show you is come from two parts. I'm going to talk about primarily in the WHI trials that were starting on average age for women of 63, but she divided it out. And you can't see this, but she wanted this data presented. At the very bottom of the slide, there are three columns. The first one is age 50 to 59. The second one is 60 to 69. And the third is 70 to 79. The estrogen is in blue. Placebo is in orange. And if you look on the left at that slide, you see very few absolute events. You do see benefits in terms of fewer breast cancers and less mortality, but very few events in that group. If you jump all the way over to the right-hand group, that is the women starting at age 70 to 79 when they might already have cardiovascular events or heart events, and what is an increase in heart events and in stroke and in total mortality. So that differentiation started to happen, but it didn't happen until 2013.
Wow, those statistics from the WHI trials are eye-opening. It's incredible how the age at which women start hormone therapy can make such a huge difference in outcomes. I can see why there was so much confusion and fear when the initial results came out. It's so important to look at the data in context.
And then in 2017, based on this next data that I'm going to show, we rewrote the NAMS position statement. And with that, we said, let's look at just those women that we want to start hormones on, the women under age 60 within 10 years of menopause. So the top of the slide is the conjugated equine estrogen and the synthetic medroxyprogesterone acetone trial. And the second table is the conjugated estrogen alone trial. And what you see when you have conjugated estrogens and you add progestin, the risks are in purple, and you can see them at the top, and you're going to see an increase in heart events, stroke, and blood clots, but very small numbers in this group. And then the benefits in terms of breast cancer and the all fractures, all cancers, and all-cause mortality and diabetes. Those things went down. They didn't go up. When you look at the CEE trial, you're going to actually see more dramatic benefits because estrogen alone has a very different effect than when you combine it with the progestin. And you'll see that the heart events did not. They went down instead of going up. We saw a slight increase in blood clots because it's an oral product. We saw, again, a true decrease in breast cancer, fewer cases, decrease in fractures, decrease in all-cause mortality, and a decrease in diabetes. So I really want you to focus on that data because what we're telling you is that if women are between 50 and 59, the outcomes are more favorable in that young age group and also more favorable for estrogen alone than the synthetic progestin. They only looked at one formulation. You've heard transdermal is different. You've heard progesterone is different from the synthetic progestin, but that's not what was tested in this trial. And everything and every warning that is on systemic estrogen is based on this trial and the data across the board, not the data that ought to be being put out, which is the data from 50 to 59. And E alone is significantly better for younger women in terms of heart attacks, all-cause mortality, and the global index than women who are 70. And over the long term, which I'm not presenting that data, but what they found was that estrogen alone led to a reduction in breast cancer incidence and a reduction in breast cancer mortality. Estrogen and progestin did not show an increase in breast cancer mortality, although a slight increase in breast cancer risk. And what we know from the French E3N study is that there's less risk when you add progesterone than the synthetic progestins. So, Dr. Manson, thank you very much for your data and all the work that you've done. And then I'm going to switch over and become myself. So now I'm Dr. Pinkerton, and I was the past president of NAMS and executive emeritus director, and here to talk about this. And what I want you to think about is my patient, Joyce. So she's had genitourinary syndrome of menopause. I'm going to call it GSM. And I've tried to help her. She stopped having sex because it was so painful. This year she comes in, she's having recurrent urinary tract infections. She's had 3 in the past year. One of them made her really sick. She almost was septic. And so I convince her. I do a vaginal pH. I show her that she's got a pH of 7. I talk about all the changes. She says, I'm going to do it. I'm going to do it this time, Dr. Pinkerton. She goes home. She pulls out the tube of estrogen, and it says, warning, endometrial cancer, cardiovascular disorders, probable dementia, and breast cancer. She looks at it. Her partner or spouse looks at it, and they throw it in the trash because they're afraid that improving their sex lives is going to cause breast cancer, dementia, or death from heart attack or stroke.
That story about Joyce really hits home. It shows just how much misinformation and scary warnings can affect real people's decisions and quality of life. It's heartbreaking to think that women are suffering because of outdated or misleading labels. This is why clear, science-based communication is so crucial.
Why is sex important if it's going to kill me? To be able to do it. So I want to make the point that, and I know that Heather said this, but the boxed warning is not supported by science. It harms women. It reflects an estrogen class labeling, which was extrapolated from the systemic hormone therapy trial that I just showed you, average age 63. It overstates risk. There is an absence of randomized clinical trial or consistent observational evidence linking vaginal estrogen to GSM to cancer, heart disease, dementia, blood clots, or stroke. And if you look at blood levels for systemic hormone therapy, they are dramatically higher than the levels we see with these local vaginal estrogens dosed to treat GSM. Dr. Santon has shown that our basal estradiol levels when we're postmenopausal range from 1.5 to 12 picograms per ml, median of 4.5. When he looked at all of these low-dose therapies, the range was 4 to 14 picograms per ml. Notice that's essentially the same. The vaginal ring goes up to 19 on day 2 and then is not detectable for the next 3 months in women. And so therefore, whether it's a vaginal tablet, an insert, the ring dosed for GSM, or the creams that are dosed low, we do not have any biological mechanism to explain how it could cause heart disease or stroke or blood clot or dementia. And then I want to show you a recent paper. It was published in the American Journal of OBGYN in 2025 by Bestie. She did a systematic review and a meta-analysis and looked at women who were on breast cancer using these low-dose vaginal therapies for GSM. If you look, the risk line, the hazard ratio is that black line going right down the middle. If you're on the right, it increases your risk. If it's on the left, it decreases your risk. The studies were all on the left. A few of them approached 1, which means it's not statistically significant. But then when she put them all together, she saw no increased risk of, and the particular slide is on the recurrence of breast cancer, but she also shows in her paper no increased risk of breast cancer, recurrence, overall mortality in women with breast cancer using these vaginal therapies. Endometrial safety has been shown by Dr. Crandall, systematic review, trials up to 52 weeks, no increased risk. So I am begging the FDA, and all of us are begging, please remove the box label. Put a warning, if you bleed, you need to be evaluated for that rare risk of endometrial cancer. If you've had an estrogen-sensitive cancer, please include your oncologist, and please stop harming women.
Thanks for sticking with me through this important conversation. The big picture: hormone therapy isn't one size fits all, and misinformation, whether from outdated studies or overly broad warnings, can have real, lasting harm on women's health and quality of life. If you're considering hormone therapy or helping a patient decide, it's crucial to understand the nuances. Here's some key take-home messages on hormone therapy. Timing matters. Starting hormone therapy within 10 years of menopause and before age 60 tends to have more favorable outcomes. And formulation matters. 17-beta-estradiol and micronized progesterone may have different safety profiles than older synthetic hormones tested in a WHI study. And route matters. Oral, transdermal, or vaginal estrogen affect the body differently with different risk profiles. Vaginal estrogen is different. Low-dose therapies for genital urinary syndrome of menopause, known as GSM, have minimal systemic absorption and no proven increase in breast cancer recurrence, heart disease, stroke, or dementia. And outdated warnings can harm. Box warnings on vaginal estrogen are based on systemic data, not local therapy evidence, and may lead women to avoid beneficial treatment. Risk-benefit decisions should consider age, symptoms, and personal health history and patient goals. I hope you've enjoyed this video, and if you do, hit the like and subscribe button and share with others. Until next time.